So it's a pleasure to be here again. I think this kind of a small meeting in a very special area these are always the best meetings. So since I saw in the program that I'm starting this part, and I saw also that we have some excellent geneticists following me, so I tried to put some kind of a introduction to the field and show where we eventually are at this moment. So as we are all interested in the lymphatic area, I wanted to share this algorithm that we had in this review, because I think that especially those who are new in the field, it might be of interest. We see that from the vascular network, when we publish some this kind of expert opinions or algorithms, oftentimes the clinicians are very happy about them because they are very clinically oriented, although they are often also based on basic science data. But so basically, the lymphatic anomalies, I think we can put them into two groups, lymphedemas and the lymphatic malformations. And then on the other hand, in the lymphedema side, which is a major interest of us actually currently, we have many of those that are just isolated primary lymphedemas. I'm not talking about secondary lymphedemas here. Then we have those that have associated signs or symptoms in other organs. So it's not only isolated primary lympha, and then those that have visceral organ involvement. In the isolated, classically, they have been defined depending on the age of onset. It can be in utero, at birth, late onset. And then we have these that are called syndromic, and oftentimes the other signs may even be the first signs that the patient comes to, perhaps to see a geneticist rather than a pediatrician. It always depends. So this already shows how variable also the entry point may be for the different patients involved or who are affected with one of these diseases. And then we have the ones with visceral and organ involvement, bone involvement. We are in the area of the complex or complicated lymphatic anomalies, where we put these terms underneath. And I think this is the perfect group always to discuss what are the terms that we should be using. And you can see here also the generalized lymphatic dysplasia, especially used for some genetic conditions where we have a very generalized lymphatic problem. Then we have the malformations, where again, we usually have these isolated one, or they can be combined with venous, but they don't have other organ systems involved. And then we have the ones with associated signs and symptoms. And those, again, so classically in genetics are called syndromic ones. For example, CLOVES or Klippel-Trenaunay or PROS. So for somebody who's new to the field, I think this gives already quite a good overview of what the field is about. And there is this notion that these entities can evolve and do evolve in time. So whatever you see at birth is not necessarily the whole story. And we also now know that will be discussed today that there are genes involved in all of these entities or groups of entities. They are mostly germline on the lymphedemas. There's about 32 genes now for isolated and syndromic lymphedemas identified, which only explain about 10% clearly of patients. And then in the complex CLAs, we have germline and somatic mutations. And then in the malformations, mostly somatic mutations. I think since the 2009 discovery that activating TIE2 mutations cause venous malformations, the whole area has just bloomed. And we are in a completely different situation today than where we were 2008. This is also something that we draw. This was a review with Taija Mäkinen's group in Uppsala and Kari Alitalo. And again, this is how we kind of thought that could be helpful for individuals to understand what is the difference between a cystic lymphatic malformation and a complex lymphatic anomaly. It's not perfect. It's kind of a drawing what we think, but at least it can help individuals new to the field. Perhaps experts don't completely agree. We put here also this dashed line because we think that the CCLA perhaps sometimes is identified as the sole problem. But on the other hand, it can also be part of GLA, GSD, and KLA. And we know now much more of phenotypes where CCLA can be present. So it's part of the spectrum here of this design. And so coming to that, oftentimes it's good also to go to the literature when we are looking at different diseases. And actually, the lymphatic problems had been recognized as being part of Noonan syndrome already in the literature in the 70s. Here are just two examples, but there are others. And this has kind of been overlooked, probably again because we are in silos. The geneticists were not that interested in lymphatics, and those who were interested in lymphatics were not interested in Noonan syndrome necessarily. But now we know that Noonan syndrome has RAS pathway mutations. They are so-called RASopathies. And since very often genetic diseases have an extremely wide spectrum of phenotypes, an individual may have the mutation, has no phenotype, another individual has a full-blown phenotype. So the expressivity and penetrance vary a lot between different individuals. So how many genes do we now then have and biological pathways involved? This is a scheme putting together all those genes that have been identified in lymphatic problems, if I can put it that way. You can see at the bottom, some of them are confirmed, all those in orange. Some are in CLAs only, and this is already 2 years old paper review. And then the green ones are known factors in these signaling pathways, but for which actually no clear data for having mutations in lymphatic problems had been shown, but that link the activities of these proteins. So this is all something that is happening in probably all endothelial cells, whether vascular or lymphatic. And something that is very crucial here seems to be that of the VEGF-C, VEGFR3 signaling pathway, which is also known as, and it was the first lymphangiogenic factor that was cloned. In addition, you have a group of genes here, and I already gave the term RASopathies. And so if we look at more clearly, actually, this is the RASopathy pathway that is very well known. And actually, it's again another group of people who are interested in various types of RASopathies. So we all in these different bubbles, which I feel more and more as I get older, that our field and the basic science and even medicine is full of small bubbles. And so here you can see also the CMAVM has been now added to the RASopathies, but then you have the neurofibromatosis, Costello syndrome, CFC, etc. And all of these genes have been identified to be mutated in these Noonan syndrome or RASopathy syndrome or like syndromes. So they are all very good candidate genes, of course, then to our field of complex lymphatic anomalies, because it has already been known that clinically people with Noonan syndrome can have CLA or CCLA. And to continue for this spectrum, I wanted to just show a couple of slides of this study that we published a year ago. It was a great collaboration with different clinical centers, including CHOP, and especially Natasha Harvey from Australia for the basic science part for making mouse studies. We identified these 6 families with recessive mutations. So these are not somatic mutations. These are inherited mutations in a gene that is called MyoD. Here you don't see it. Myoblast determination family inhibitor domain containing, MyoD. MDIC. And in this gene, the individuals have both alleles mutated. And basically, we think that there's a loss of function of the protein. These patients in these 6 families, the 7 patients, some of them died actually, unfortunately, very, very early. They had fetal hydrops, postnatal lymphedema, pleural and pericardial effusions, and chylosositis. And Natasha also created a mouse model for this. And again, there was the same problem, very disturbed lymphatic function with chylosositis. So clearly a gene that is also involved in the phenotypes that we are interested in. What is the function? When we published this, we really didn't know. We just found it. We identified the mutations. There was lots of expression studies done, but still it remained very elusive. What is very interesting is that just last week, there was a paper published in Science showing that MD-FIC, which is here in green, these little things here, actually associates with another gene that we know in our field of lymphedemas, which is an ion channel called piezo-1. All the other parts here, the yellow, the red, the Bordeaux, they are piezo 1 units. And it seems that the MD-FIC, here looking from above, here looking from the side, somehow integrates and regulates this ion channel. In this drawing, you can perhaps more clearly imagine here a cell membrane with the outer and inner leaflet, the piezo channel, the 3 subunits here, and the MD-FIC laterally going into this structure. And clearly they showed, I'm not going to the details, that it regulates the activity of the channel. So one can imagine that with the mutations, the channel properties are now altered. So if we come back to this basis of CLAs, it seems that the piezo channel that was already in the figure now also may be involved and functioning with MD-FIC, this new gene for at least primary lymphedema with complex lymphatic anomaly associated with it. MD-FIC also associates with GATA2, so it may have different functions. So if we are thinking of therapies for the future, it's not always that simple, although the piezo channel might be one of those properties that we might want to study. What is piezo 1 doing? It is an extremely well-known flow sensor, mechanotransductor. And that, of course, may be something that is important in the future. If the mechanotransduction system does not work correctly, and this is actually the topic of our current LEDUC grant that we are working on, it is how do different vascular beds sense, and how do mutations in all the different genes that we are interested in, how are they affected with different types of flow? But so it might also well be that on the lymphatic side, there is a similar defect in this sensing. And so it could be another type of a target when treating CLAs. And so for treatment, just to finish, I don't think I have a lot of time left. If we come back to this picture, what is, of course, interesting is that on the right side, most of the mutations that we know, the mosaic somatic mutations, kind of cause an hyperplasia in the vascular system of the lymphatic system. And if we go to the pathways that you now know all very well and the different CLAs, we know that these 2 major pathways that also in the patient presentation was already mentioned, the NRAS mutation, are involved in many of our patients. And so the inhibitors, of course, are now being used off-label or in clinical trials. And it is great to see that this is giving new hope for many of these patients. But could it also then be that the other aspects, such as the flow, could be added to those? And so in this field, we have moved from the very severe adult patients to treat then children. And so a couple of years ago, we had this couple who came for a second opinion because their fetus, the child, still during pregnancy, was creating a huge lymphatic malformation around the head and neck. And they absolutely did not want to abort the pregnancy. And as we followed for a week, the lymphatic malformation was growing very rapidly. And so, since sirolimus had already been now used for years and had been tested first in adults and then in children, and there were notions of some pregnancies where the mothers had taken sirolimus for their own disease, it reduced the probability that there would be any problems for the fetus, although the fetus had not been treated with sirolimus. But so we decided, after long discussions with the parents and also the ethics committee, to start the sirolimus via the mother. And you can see in blue how the maternal levels of sirolimus slowly went up. And this also was then followed by the fetal serum levels going up. About 1/3 went to the umbilical cord blood. And you can see also that as this concentration started to go up, the size of the lymphatic malformation really started to diminish fairly rapidly. And so she was then born at term. She still had residual lesion on the neck region. And this has since been treated by sirolimus and surgery, as you can see already here. And she's now actually 7 years old and doing very well. She's at school. So we're very happy with all the results, although all this time and follow-up was stressful because this had not been done for a lymphatic malformation before. But clearly it opens the doors for thinking that how early is early. We have always said that we should start treating lymphatic and vascular malformations as early as possible so that we can prevent the growth of the lesions, because we know that all of these lesions develop slowly, they progress slowly. But so this is very early treatment here, and I think that with the international collaborations with all the colleagues, it's a very good idea to try to have some kind of a consensus as into indications and what are the situations in which this eventually should be proposed. But this got, of course, a lot of attention because when it's a mother, it's a fetus, the public is extremely interested in something like that. It's just completely different than saying that we treated an adult patient with something. That's not very interesting. But when it's a child and the mother, the situation is completely different. So in conclusion, CLAs, I think, are very heterogeneous as phenotypes, and I think we all know that. We have germline mutations. We have germline rasopathy mutations, Noonan gene mutations. We also have the PSO1, MDFIC, and other genes that can be also germline mutations. So one needs to keep that in mind, and also the genetic counseling. Then I think Dong will talk a lot about the somatic mosaic, RAS and PI3 kinase signaling pathway activating mutations, which also many of the patients have. And so the repurposing of the RAS and PI3 kinase signaling defects are definitely good targets for repurposing cancer drugs. And that, of course, includes the patients with Noonan syndromes with germline activating RAS pathway mutations. And so for the early treatment, definitely it seems that it can be efficacious for a lymphatic problem. But I think the big question then is, well, when and with what, which molecules? Sirolimus luckily has been used already for many different diseases, so we have much more knowledge. So it was much easier to start with that, even if we didn't know that the baby had PI3 kinase mutation. We did find it a posteriori, but we didn't know that in utero. So I would just like to thank and mention the group, my group with lots of young enthusiastic people doing studies in this field. And of course, Laurence, who's coordinating the Vascular Anomaly Center in our hospital. Also the many funding agencies, all the people who are collaborating and have collaborated with us. And then the Vascular Network, which I think is really giving a new momentum in, at least on the European continent. We have now 14 countries with 14 centers, each center represented by 2 people, so 28 experts, and importantly, the patient advocacy group, which now contains 7 different associations. And this is our network meeting a month ago, more or less, in Brussels. We were able to have more people from the different centers, and we are now altogether 140 from the same 14 centers only. So we hope that this gives a possibility to more rapidly do basic science, but especially translational and clinical studies in CLAs and other vascular anomalies. Battery is running low. Perhaps it's me. It's true that it's late. Whoops. But that's it. Well, yes, for this community, perhaps it's of interest that since we had this network meeting, we also decided to create some task forces, and Wilmijn Klein is here, and she's going to talk, I think, tomorrow morning. She's a radiologist, interventional radiologist, and very specialized in the CLA field, and really, I would say, coordinating the activities on the European side, at least on the vascular network, and with Isabelle Guéret, who is more on the primary lymphedema side. So they are chairing a new task force on CLAs. And I'm myself more there as a liaison person. And then we have Mary Kennery from the EPAC that will be also part of the task force. So with that, I thank you for your attention.